My name is Chris Peters. I'm a child and adolescent psychiatrist. Also work some with adults. I work for the University of Louisville at a place called the Bingham Clinic, which is located downtown, downtown Norton's Hospital. It's actually the fourth oldest child guidance clinic in the country. Kind of unique. It's been around a while. I'm part of a committee that works with the University of Louisville Depression Center. There's 20 plus depression centers in the country located at different universities throughout the country. And the goal was to create sort of a program that you see with illnesses like cancer treatment. That you have sort of academic centers throughout the country that share data and information so that then you can do a better job globally at coming up with more effective treatments. So the depression centers are sort of one big group, and we're fortunate to have one here at the University of Louisville. So part of that is a sort of community outreach and to do some educational sort of experiences throughout the year. And one of those we dedicate to sort of children and adolescent mental health issues. So tonight we'll focus a little bit on depression. And it's a small enough group, we can probably, if you want to stop and ask a question, certainly do so. But I will try to get us completed and done by 8 o'clock. I don't have any disclosures. I don't have any relationships with any pharmaceutical companies or anything like that. So what you're hearing is sort of my take on the information and no one else's. Again, we'll talk about depression and how it can look in children and adolescents and maybe how that can be different than if you're working or dealing with it as an adult. And then we'll talk about treatment options that may vary a little bit in terms of what we do with children and adolescents dealing with depression. But so this just kind of bring us in. This particular page is a list of psychiatric illnesses that are not uncommon in children and adolescents, just to kind of give you the landscape of the commonality. Depression, and we'll talk about how common it is, can occur in up to 8% of adolescents any given time. That's kind of on the high end of the diagnosis. Studies will range anywhere from 4 to 8% at any given time. And you can see anxiety illnesses are also not uncommon. And I think a theme you'll hear tonight is psychiatric illness rarely travels alone in young people. And so if you have a depression, it's not uncommon to perhaps have a second disorder that could be anxiety related, substance related, or something alike. So yeah, my take home here, like if you have 100 depressed youth, up to a half may have other co-occurring diagnosis that may impact your treatment response, right? So you may have to do a couple of things to address a couple of issues that may be occurring. We'll focus tonight on major depression, but there are sort of a litany of different ways to present with depression. There's something called dysthymia, which is kind of a low-grade chronic depression that's slightly less impairing, but more long-standing. And so this would be a group of symptoms you might have over a period of a year for youth, or 2 years for an adult to even meet the diagnosis. Major depression is much more acute and condensed. The symptoms hit quickly, can occur over several weeks, and then you can meet the criteria for diagnosis. The other thing, as a psychiatrist, I don't want to do is call something a major depression if it's related to maybe a medical illness that's causing it. So if they have a thyroid that's not functioning correctly that's causing the depressive symptoms, I don't want to treat them for major depression until I correct the medical cause. Or if someone is abusing the substance that is known to cause depression, you don't want to then ignore that and try to treat the depression without addressing the substance use. So we have a diagnostics and statistics manual that they refer to as DSM. We now have the 5th edition, the 5th volume of that. Mainly the diagnosis of depression has not varied a whole lot over the volumes of the diagnostic manual. And we'll talk a little bit about how kids look a little differently when they're depressed than you might think of them looking as if they were adults. Some of the things you'll see more commonly is irritability. So kids will tend to self-describe less sadness and more irritable, moody when they're not feeling well emotionally. So you may not necessarily think depression as much as just irritable, angry kinds of experiences when you're around them. And again, anxiety may also be the presenting variable. Behavioral problems, much more oppositional and defiant, and conduct-related issues can occur in up to maybe a half of kids who are depressed. Treat the depression and sometimes the behavior would improve, right? All right, so let's think of a question. We'll have questions sort of thrown out to make it a little more interesting. So if we think clinically of major depression in prepubertal children, so these would be young school-age kids, that how would they differ from adults and how they might have symptoms of depression? So would they be more likely to have insomnia, irritable mood, impaired attention, decreased appetite, or what we call psychomotor retardation, which is a slowing down, just everything's a chore, to move or to get up and do it. So if you go by what I said last slide, right, irritable mood, right, irritability. The others you would see more commonly in older people who are dealing with depression, perhaps. The problem with irritability is it's not very specific. A lot of things can make you irritable. You didn't sleep well, you had a tough morning, you're kind of edgy and irritable. So we're looking for irritability over a period of time that's impairing my function, right? It's not a bad day, it's a bad 3 weeks that's consistent and pervasive, and it's impairing what I do and how I do it. So this is compared to older teens with depression, children's in that school age with depression most often. So which of the following? So delusions is a fixed false belief. It's something I believe that's not true. Okay. Anhedonia is I've lost the ability to experience joy and happiness. Okay. Hypersomnia, meaning sleeping too much, hopelessness, or what we call somatic complaints. My tummy hurts, my head hurts. There's no real good explanation for the physical complaints. So what do you think a younger kid might have compared to?
Can I guess this?
Yeah, sure, absolutely.
E?
Right, so kids have less verbiage for how they might express or deal with emotional world. And so a lot of times they have somatic kinds of complaints with how they might present. Mm-hmm. So if you have a kid, a youngster who's always complaining physically of something, the head hurts, stomach hurts, and we go to the doctor and they can't quite find anything, and then we come back and we go back again. Then you start to think, well, maybe there's an emotional, anxious, depressive cause that may be underlying that element.
Could you give me the definition of the B again?
Anhedonia.
Mm-hmm.
It means that you've lost the ability to experience joy or pleasure.
Okay.
So something I used to enjoy, and now I don't look forward to, I don't find myself motivated to do it. I used to love playing X, Y, or Z, and I could care less. That would be an anhedonia, which is very common in depression. You start to pull away from things that used to be enjoyable. And you'll see that in kids and teens. They'll pull away from things. They used to play a sport. They used to be involved in things, and you start to see them isolating, pulling away from friends, things like that, without a good explanation. Criteria-wise, depression episode is really looking at a 2-week span of time at minimum. So it has to be at least 2 weeks long, where you have 5 or more of the following symptoms, one of which has to be a mood issue, a depressed mood or an irritable mood, or the anhedonic experience. And then you have a litany of other symptoms you may have, right? Changes in my appetite, where I'm losing weight, gaining weight. Changes in my sleep, where I'm not sleeping or sleeping too much. My energy level may be different. Fatigue. I can't think as clearly. I'm not focused. I'm not concentrating. I'm being distracted. I may have darker thoughts. Right? I'm down on myself, more negative thinking. Suicidal thinking is very much a part of the depression constellation. Feelings of worthlessness or guilt. So you don't have to have them all. Right? 5 of them over a period of at least 2 weeks. And then you have to be impaired by them. So again, it has to be at a level that is creating a change in your usual functionality. And again, we tend to be more moody. Children do, right? A lot more behavioral acting out can be an issue. And social withdrawal in some kids. And I made several slides kind of looking again at how kids can look a little different. The younger kids, right, we talked about somatization or somatic complaints, headaches, belly aches, things that aren't as well explained. And they'll have that high instance of anxiety along with the depression. So this is a sad kid, a struggling kid who's also very anxious, unsure of themselves, clearly aren't confident and may have other anxieties coming through, which may again affect their behavior. Now that they don't want to go to school and they're acting out, tantruming because of that, not because they're particularly hating school, but they're not feeling well enough to take on that aspect of their life. Adolescents will tend to sleep more, withdrawal. Now the problem with that is adolescents tend to sleep more, disappear in their room. So again, it's how different from the norm. Is it impairing, right? Because if you have teens, they may not say a whole lot to you sometimes, and it's hard to know kind of what's going on with them. But then how are they functioning is the key. What is school going like? Are they involved in other activities that are, pro-social or healthier kinds of things?
Do you see overlap between when you have children, like, say for instance, you have a teenager that's like 13 or 14 that technically hasn't started menstruation yet.
Mm-hmm, right.
So you still have like this half child, half teenager.
Sure.
Do you see a lot of overlap?
And there's overlap across the board.
Okay.
It's just, I'm talking sort of averages.
Okay.
But I can have a very somatic teen who's
Okay.
post-puberty. They can present that way. So it's not absolute, but it's more common for younger kids to be somatic, as very elderly folks who are depressed to be somatic. So again, it's not exclusive to the young people, but our developmental phase of life can affect sometimes how we present. So you're absolutely correct. All right, so this is a little mnemonic, and if you ever tried to memorize these things. So when we write prescriptions, we write SIG, which is a Latin insignia for directions, and we're prescribing ECAPs, energy caps. So that's your mnemonic for the symptoms of depression. So if you ever wanted to recall those. Sleep changes, interest changes, guilt, energy changes, right? Concentration, appetite, suicidal thinking. That's what we were just listing off, right? Now you can subdivide depression, mild, moderate, severe, right? So how many symptoms you have is one way to quantify it. So you just met criteria, it might be more of a mild. You're not as impaired, right? So there's some subjective component to where you place them on the mild, moderate, severe. People who are severely depressed can have a break with reality, right? So they can have psychotic symptoms. They may hear things that aren't truly there in a very negative connotation. They may have very fixed negative beliefs that aren't true. So that's kind of your severest depressive episode, but that can happen. So for young people, you would likely come across them as their first episode they've had. Becomes important because some people who then recover are at risk for a second episode at some point in their life. They're at a little higher risk than somebody who's never had an episode. So that's important when you talk with young people and families. Say, hey, will we ever have to deal with this again? We say, well, it's about 50-50. It's 50-50 in terms of whether you'd have another episode in your lifetime. There's different ways to describe the features, and for young people, they may look more atypical, which just means they can look happy at times. So if something good is going on in that moment, they might perk them up. And so they have a certain mood reactivity. They're not just stuck in the cellar of the mood. But as soon as that activity's gone, then they're kind of right back in the darker place. And then they really intense low energy, and some will complain of almost a heaviness to their movement. They call it leaden paralysis. This sort of everything is almost a pain to do or to move or to get things done. And they're usually eating more and sleeping more, so that's the sort of hibernation effect for some people in the atypical presentation. Some people have triggered by season, right? The fall when the days get shorter, for some people is very difficult and their mood may shift and change. And for the more vulnerable, that can trigger depression. I will say then shifting into the spring is also another time that can trigger it for some people. So seasonal shifts for us can get busier because some people are more vulnerable to that. And for young ladies who may become pregnant in young adulthood, that's a very high risk time if they're vulnerable to any kind of mood or anxiety illness. It's the highest risk time for any woman in their lifetime is during or postpartum for a psychiatric struggle. All right. So we've kind of hit on this a little bit. Thankfully, it's not overly common, but it's something that you can deal with. Children probably have about a 2% prevalence rate. So a point prevalence is at any point in time, if I take a picture of the population of children, 2% would likely meet criteria for depression. Okay. The same with adolescents. I take a point in time, 4 to 8%. So those are the percentages of people that are probably walking around dealing with depression at any given point in time. In terms of male to female ratio, it's equal before puberty. Once we go through puberty, the risk for depression goes up in females, so it's about a 2-to-1 ratio after that, female to male. I think the other thing you'll see here tonight is it's not just biologically driven, but it certainly has a biological component. And so they say, how do you know that? Well, if you look in families where depression runs in the family, okay, if you have generations where there's been folks who've had depression, then that child is at higher risk for depression. Doesn't mean they'll have depression, but their risk goes up. If I take a child from a family that's had depression, and they get adopted into a family that doesn't have depression, they carry a higher risk with them. Okay. Does that make sense? So there is a genetic vulnerability, we believe, that puts people more at risk for things like a mood illness. If you have identical twins, and one is depressed, the other one is about 50% risk for depression. Much higher than the 4 to 8% rate we talked about general population. Right? So we know that genetically. If you have non-identical twins, it's still a higher rate, 25%, but it's not as much as the 50. So again, there's a genetic component, but it doesn't explain it all, right?
Do you find social classes have certain depression rates more than the others?
Absolutely. And we'll have a slide or two that I think talk about risk factors, and you'll see that one of the risk factors is your socioeconomic strata, resources, things like that. Put you at high risk for a lot of things, right? So what if you have depression as a child, as a youth, how long does it last? So before we had some of the treatments we have now, people, like if you go back to the 60s, 70s, people who were severely depressed might get hospitalized until the depression was at a point where they could leave the hospital. And so the duration of the illness would kind of keep them in the hospital. And that can be anywhere from 6 months to a year to 2 years. Right? So the illness can sustain. If you follow kids out, it's about an average of 8 months for most kids. So you're just under a year in terms of an episode, right? But some can again prolong over 1 to 2 years. And part of that is what you were bringing up is, life is going on around you, so things may not be shaping up to help you manage the depression, maybe working against you a little bit, right? So that makes it a lot harder in terms of treatment. There's also a potential of recurrence, after you follow kids out for 4 or 5 years, that they might have another episode. So it's not everybody, but it is a higher risk for sure. Now this number is a little tricky.
This is the one I was just going to ask.
If you think about bipolar disorder, it is a mood disorder. So we have depression, what we call unipolar depression. That's what I'm talking about right now, where people have had a depressive episode, and they may be at risk to have other depressive episodes. We'll call that unipolar. Bipolar people get depressed in just the same way, right? But they have a caveat. They have had to have had an episode of mania sometime in their illness. The problem with youth is they may first present with depression, and I don't know if that's a unipolar depression or a bipolar depression.
Until they have mania.
Right, until it would define itself more fully. Right. So it's tricky. So then, folks in my position would be, well, are there things that would clue me in that would help me decide how to treat if it's unipolar or bipolar? Because it may affect what I decide to do. And it's not black and white. It's a difficult thing to do. I think the 40% is an aggressive number. I think the 20% is probably a more accurate number. That people who present depressed in their youth, about 1 in 5 could later show that depression was part of a bipolar illness and not a unipolar illness. Does that make sense? The other thing about kids are thermometers for their environment, their families, right? And because of that, they're much more influenced by it. So the younger they are, probably the more influenced. So if they have a lot of stress going on in the family or in school and bullying situations, that's going to have a much greater impact on someone who's still developing coping than an adult who's already established coping, right? And so part of intervention then is to try to help the environment stabilize as much as you can if there are factors there that will help the treatment course as well. And that just kind of restates the same thing. And again, it's important to state, again, I think we'd all have that common sense element that the more things you're dealing with in life, the harder the recovery will be. That's just how it goes for most things. If you're homeless and you don't have food and you're depressed and you can't get the medicine and you can't find the therapist that's not an hour away, all those things are going to really impair your improvement. All right, so we talked about it has to impair function, and then the other difficult thing is it's a type of illness that can impact one's thinking to the point of hopelessness and that there's no other solution, and I'd be better off not here. And so some people will begin to entertain suicidal thinking, even to the point of planning or attempting or completing suicide. And kids are not immune to that. And in adolescence, it's the third leading cause of death. Okay. So it's something that we, spend a lot of time on and try how to intervene as best we can at a prevention level, at a public health level. And try to figure out what things we can do within the schools and things that might help prevent kids from going down that path. So I have a few slides again, and I think we hit it already about the unipolar versus bipolar. This was huge. If you go back 10 years running, there was an overuse of bipolar diagnosis in children, probably because we didn't quite know how to frame some kids who were having much difficulty with their anger control and aggression and outbursts and things. And so it got kind of overutilized in places it probably shouldn't have. The problem with using the diagnosis is it implies a certain treatment, certain types of medicines and things. So if you call somebody that, you're sort of saying we're committing you to certain treatments. So you better be as sure as you can that it's accurate.
What were the criteria for a manic?
So mania is a period of time where your brain is sort of in an overactive state. So people will complain or report racing thoughts. Too many thoughts at one time. I cannot keep up. Too many ideas. I'm very creative. I may talk, pressured. I can't stop talking. I may have multiple ideas and I just keep going. And I got this idea, and you and I, after this, we're going to go do something, and then we'll meet up and do that. And I don't need to rest. It's fantastic. Some people like the feeling, which becomes even more difficult. Some people find it very negative and unpleasant, but it's driven. And there's a decreased need for sleep. So I don't need to sleep. It's not that I can't sleep. That's a different complaint. I'm tired, I'm trying to sleep and can't. That's more of a depressive experience. I don't need it. I
So
slept
it's
2
not
hours. I'm
necessarily
fine.
insomnia, it's not necessarily explained by
Right.
insomnia.
Yes, I'm sleeping 2 hours a night, and they say, well, gosh, you got insomnia. Well, but I don't need it. I have plenty of energy. I'm
feel
not
great.
tired. I can do all kinds of things. I'm being very productive. But I may also be very reckless, very impulsive. I may act in ways that are not typical, very poor judgment, spending money I don't have, doing things that are disinhibited, that are out of character. As it continues, then I may lose touch with reality. And that's when you see things with grandiose sort of beliefs about myself, or I'm getting messages from higher up, telling me to do this. I had a young man who had a manic episode in college, and he truly believed that he was the one source that brought all religions together. And so he was going around preaching to different places, and he was constantly on the move, right? And eventually your body begins to shut down.
Now, can we go back to the previous slide for a moment?
Yeah, sure.
About the suicidality, so more males than females complete suicide.
Correct.
But by the teenage years, the ratio is 2-to-1, females being depressed.
Correct.
Yes, okay.
And it tends to be that males will pick a more permanent way to hurt themselves.
Okay.
So women actually attempt suicide more often, but it tends to be least lethal means, whereas males attempt less often but use more lethal means, so complete more
So
often.
that's completed suicide.
That is correct.
There. And does that include reckless behavior? I remember hearing a long time ago that it was thought that maybe some depression for young males, it was just, incredibly reckless behavior, so you get yourself killed, but it
Yeah.
wasn't that you shot yourself.
These numbers would only include known
Okay.
suicides, yeah.
Okay.
So there may be
So even with
percentages that
Okay.
that's behavior that maybe it was that, but we'd be able to call it that specifically.
Okay.
The one thing I'll say, if someone is bipolar and they're depressed, but I don't think of them as bipolar, I just see them as depressed, right? I don't know yet. And I treat them with an antidepressant. That some folks can worsen if they're bipolar. It can trigger a mania.
And then don't you have to start on like a mood stabilizer?
Right, so it would change your whole understanding of their diagnosis at that point. And so one of the things that is predictive of a bipolar illness versus a unipolar illness is a manic response or hypomanic response on an antidepressant. So I think it's, we'll talk about it in a couple of slides. There was a study where in a minute. So this is exactly our topic. What predicts bipolar in teens who present with depression? Right, so I have this depressed teen, and I'm thinking, could this be bipolar depression? Is it that they have lower IQ? Is that a clue? Is it they're suicidal? Is it they're psychotic? They had good function before they got sick, or it was a slow onset of depression? What would give me any clue? All right. So the answer is psychosis. And so the more severe and sudden something like a depression is, that could be bipolar depression. It tends to come on a little quicker. It's not insidious. It's not a slow onset. It comes on a little quicker, and it tends to be more severe, at least in the youth. So that it's not absolute. I can't bet on that, but it gets me thinking more that could be bipolar depression. I don't know why that happened. Enjoying the same things. So these are risk factors, right? Again, these are just things that someone may be experiencing or have experienced that raises their risk of a depression. And this is true in youth as well as adults, right? So life stressors, you'll see many on here. We talked about being female post-puberty, higher risk, around the peripartum time period. So we know there's hormonal influences related to depression risk. Obviously stressful life events and losses. The usual age of onset of depression tends to be young adulthood up through middle adulthood. Our group, is a little earlier in their onset. Okay. So why do people get depressed?
So
What causes it?
it's a biological thing,
Right, so there's biological influence.
probably chemical.
Right,
Like
we'll
bring
include,
in
we'll include that
chemicals.
in biology. Brain
Probably that you can
chemicals,
bring chemicals in that would cause
substance
depression.
related, okay.
Okay.
So we'll call that sort of the social influence that creates biological change,
Hormones,
right? Biologic.
go back to biological.
Is your environment biological?
Right, so we'll call that social. You may have certain psychological elements to your personality and style that put you at more risk. So that's where we come up with the word biopsychosocial. It's not all one thing. It's the sort of combination of variables that are coming together. And we call that kind of a stress diathesis model. And we think that influences in vulnerable folks changes in their brain chemistry, and they have certain receptor changes perhaps that then cause what we see as the depression episode, the syndrome. Okay. I wish we had that test. I wish we had that sort of objective one finding that really would clarify this. That's just not how the
One
human
day.
body works. Right?
I think one day we will.
Maybe. And so the idea is I carry a vulnerability. We talked about my genetic vulnerability, right? I have certain biological things that may put me at risk, and then life hits me with things. And if I'm young, I may not be coping well. Even if I'm older, I may not be coping. But certainly more vulnerable as a youth. And that constellation may be enough then to trigger what would be a depression episode. There's some information that suggests certain receptors in the brain, if I have certain genetic makeup for that receptor, different from somebody else, that have a certain type, I may be more vulnerable to depression following a stressful life event. Okay. It's not absolute, but there's some data that suggests then if I have this certain genetic makeup for this receptor, I'm more at risk if stress hits me to have depression than somebody who doesn't have that genetic makeup for that specific receptor.
So could they do a test, a genealogy, or
Yes. So they could, this is a receptor for serotonin,
Mhm.
so they could do a genetic test and look at your genetic makeup for that receptor and say, you know what, you're twice as likely at risk for depression given stressful life. Now again, there's some people who dispute the clarity of that, but I think that's the next step in terms of managing risks and knowing what receptors put people more at risk so that they can be more informed and try to manage things. So you can't take the stress out of life,
Right.
nor should you. Stress allows you to develop coping. You want kids to go through things that they then develop mastery in coping, and that's part of learning to take on life. But you want to know maybe if they're more vulnerable, so you can intervene if you see that being sort of triggered into depression. And again, this is just more sort of data about the running in families, the genetic risk, but also some modeling. I mean, you can't take that out. So you have a genetic risk if you're in a family that has depression, but you're also seeing depression if one of your parents is depressed, right? So that's influencing, your worldview in a way. So you're sort of getting both vulnerabilities there. There's a huge study in adults where they looked at treating depression over time, and they looked at mothers who had young children, and they did observations of the children as well, since the mothers were in the study. And what they found was the depressed mothers, their kids had a lot more psychiatric diagnoses: depression, anxiety, disruptive behavior. if the mother responded to the treatment during the study, so got better, the kids' symptoms, behaviors improved. The kids weren't treated specifically. The mother was treated in this particular study. If the mother did not respond to the treatment, so didn't get better during the course of the study, the kids worsened. So again, that just suggesting it's not just biological vulnerability, but also the health of the environment that it was influencing. So from my standpoint, it's very important that I not just treat a kid, but treat the whole family unit if that is indicated, or if the parents are struggling. I'm getting more bang for my buck helping them than just directing all my time at the child.
And honestly, any parent with a child with mental illness is going to be struggling in one
More
way or another.
vulnerable themselves because of the stress load.
Yeah,
Certainly.
it's just harder parenting.
Well stated. Absolutely true. Other biological kinds of things, there's something called a dexamethasone suppression test. It's not specific enough to use a whole lot, but it's used in sort of the research world and was used significantly. What it does, when your body stresses, your adrenal glands release cortisol. It's kind of a stress hormone, right? So there was a way you could suppress the hormone in the brain that's telling your adrenal glands to pump out the cortisol. So I'd give you dexamethasone, and I would measure your cortisol, and it would go down because I've given you cortisol. It doesn't need to produce it. But in folks with depression, it's just constantly going, so it wouldn't suppress. So in about half people with depression, it would suggest, hey man, this is really driven biologically. It's not enough to be a diagnostic tool in everyone. You'll miss people who are depressed just because they wouldn't have that test, so we don't use it in that way. But it again supports the idea of your body is struggling when it's depressed. It biologically is behaving differently. Sleep changes. There's neuroimaging that supports a change in your frontal lobes, your prefrontal cortex. That's where you can't focus. You're not planning things well. You can't quite get things together like you could if you weren't depressed. So your brain is struggling to function more effectively. And again, this was a side geared toward if you're taking your child to your primary care doctor, they should be screening, right, for kids and teens. Hey, have you been feeling okay the last few weeks? Have you had too many worries? Have you been feeling down? So that if there's a hit on a screen, then they can take more time. So the primary care office is very important for screening over time as they get to know your kids. And that's why one prevention way is let's make sure everybody's getting their well child and healthy kid sort of checkups so we can pick things up. All right. Questions diagnostically? I thought there was another slide. I'm going to go through this because I think it's important. So there was a study that looked at depressed kids who were hospitalized. These were teenagers who ended up on an inpatient psychiatric unit because of the severity of their depression. And then they were followed out. Okay. And about 1 in 5 later had the diagnosis of bipolar disorder. Okay. So then we came back and looked and said, how were those different than the ones who stayed unipolar depressed? What made them different? So one was they had a reaction to the antidepressant, like sort of triggering the hypomania or mania. One was a very severe sudden onset of depression, which we talked about. One was a multi-generational mood family history. So this family, has a long-standing sort of mood illness that raises that risk. Okay. So those are things that can give us clues sometimes whether we're dealing with unipolar or bipolar. It's not absolute, but it's things you can kind of look at. So before I put treatment up, your thoughts on treating children or adolescents? What do you think we should do first?
Probably start with full physical.
Right, you definitely want to make sure your diagnosis is correct.
Okay.
Right, you're going to rule out medical causes, thyroid, parathyroid, calcium kinds of things. So we're going to assume that's already been done.
Okay.
But absolutely correct.
Therapy.
You'd start with therapy.
Behavior modification therapy.
Okay. So you would do therapy before medicine?
That's where I would start.
Yeah, no, absolutely.
That's where I started with my kid. Now, whether everybody starts.
No,
there,
and I think culturally, I think you're absolutely right. Culturally, sometimes we reach for the medicine, you know, the quicker fix. So, but therapy is, particularly youth and teens, you've got to have that be a part of it. Medicines may have a role, but they're not an only role, and they're certainly not a first only role. So we'll look at therapies and talk a little bit about that. And then there are indications for medications. ECT is it's a induction of a seizure, and it's been shown to be very effective for severe depression. We don't do it in kids. It's just no CT. I've had maybe one older teen, 18, 19, very severe, but other than that, it's not something you see. It's very effective for those in the other side of the age range, in the geriatric population. They'll use it much more frequently. Light therapy, phototherapy, and that's helpful for folks with seasonal triggered depression, particularly if it's a fall onset when the day shortens, the sun goes away. And you can even buy those now on the internet. It used to be a big deal to even find one, but now for $150 you can get your
Well,
own
I think
photo
vitamin
box.
D levels come into play there
Right.
too.
And there's been a lot of play for making sure everybody's vitamin D's
Vitamin D, vitamin
up.
D.
Yeah, and eating healthier, taking your multivitamin, those kind of things, very important.
At what point I read that light therapy can be bad for people with bipolar. Is that true?
Well, anything that has the potential to trigger mania would be a problem. So hypothetically, if I'm treating my depression, could it flip me into a mania? And so that would be the risk.
Okay.
So you're always looking for ways to treat a bipolar depression that doesn't have that flip
That
risk.
doesn't flip them to one side or
Right,
the other.
Yeah.
exactly. That's exactly right. So the main therapy you'll come across in terms of working with kids and youth and teens is called cognitive behavioral therapy. And a couple of things, it's an educational approach and it's a skill acquisition, right? You're going to teach the young person skills on self-soothing, self-managing. You're going to teach them how to assess their thinking, okay? So the older tween or teen might be able to sit back and think about their thinking a little bit. So when we're depressed, our thoughts tend to be much more negative, and they may not be accurate, right? So we have to step back and look at all the evidence to correct the thought, right? Because if we believe the thought, the negative thought, then that's going to lead to the feeling, which leads to what we do. Thoughts drive the feelings, drive the doing. So if I'm thinking incorrectly, I'm not going to feel accurately, and I'll behave in ways that are not helpful and will likely reinforce the whole cycle. So we're teaching a skill of stopping, looking at the evidence, challenge your thinking. Just because your brain thinks doesn't mean it's always accurate. Take time to be your own Sherlock Holmes and decide if your thought is accurate or not. The depressed folks find that very challenging. I would say most folks do. But because they're prone to pick out the negative as accurate, and, well, that person said I'm smart, but they're just being nice, or my mom has to say that, or Dr. Peters, you're saying that because I pay you. I mean, it's not true. But if somebody says something negative, that's true. I don't even question it. So they have biases in how they interpret the world that are negative influence. So they really have to work to challenge those thinking processes. If you can get them to do that explicitly, then they kind of become their own therapist in their mind. And that's sort of the long-term goal of some cognitive therapy intervention. The other thing you want to do is activate people. So if I'm isolating, I'm not doing anything, I'm sort of closed down, I want to get them out. Exercise, I want to engage them. So that's part of some behavioral agreements and things that's part of the cognitive behavioral therapy. Okay. So I know if I can get somebody active, I can get somebody exercising, if I can get somebody socializing, those will have positive influences on them.
So
sometimes it's hard to get them to do it.
Of
Yeah,
course.
I'd say that's.
Yeah.
That's for adults too.
Absolutely. I mean, none of what I've just said goes in a straight line.
No.
And that's where if you're stuck, despite best efforts, and you're at a severity level, that's when sometimes medication may be discussed to try to bolster so we can engage more in the therapy.
So sometimes it becomes your only option once those don't work. Or-
Yeah, if you're struggling there, then you're saying, what else can we do? And if you're severe enough at the front end, some people start both. Right? We'll talk about that. So yeah, some verbiage slides, but these are all the serotonin drugs. Plus this one on the end is what they call a serotonin and norepinephrine reuptake inhibitor. But the main ones I just want you to think about are the serotonin reuptake inhibitors. Right? So these drugs act in a way that make your brain think there's more serotonin available. And that tends to infer, over a period of a few weeks, improvement in depression symptoms. Okay. On the left are several diagnoses that the drugs are indicated for. So I have my little verbiage there. So let's take OCD, obsessive compulsive disorder. Prozac, Zoloft, Luvox, and Paxil have FDA-approved indications to treat OCD in adults. These are my adult indications for my serotonin drug. This side is my pediatric indications, which is what we'll focus on tonight. So if I have a child with OCD, there are 3 medicines approved by the FDA to treat OCD. If I have a child or youth with major depression, there are 2 antidepressants that have been shown to be effective in treating depression, and we'll look at the literature for that. So that's just kind of your reference. And these are down to age 8 for Prozac and age 12 for Lexapro. A few slides about safety. So there was about 20 plus studies in young adults and youth using serotonin and other antidepressants to treat depression that showed a slight increase in some suicidal thinking and behavior in the treatment group over the placebo group. And so the concern was, is the treatment making things worse from a safety perspective than helping? And so ultimately the FDA reviewed all the studies done in children and adolescents. There's over 4,400 patients. There was never a completed suicide in any study. There was a doubling of risk. So if the placebo group had 1 patient that had a sort of worsening of suicidal thinking or behavior in the study, that meant the treatment arm had two patients. So it was a double risk. But it was a small risk. And you look at overall outcome, and we'll look at a big study, the risk of suicide went down in every treatment group. So the risk of untreated depression causing suicide is far greater than someone who's receiving appropriate treatment, that causing it. But they wanted to go ahead and put the black box warning so that discussion should occur anytime I'm prescribing an antidepressant to a child or a teen, to their family, that things could get worse. They might feel worse, so we don't want to keep them on something that they're having that experience. And so that has to be discussed. Now, a lot of the kids already have suicide, they're already experiencing that. And so it to be worse. So the next few slides you can kind of read through. It was sort of the several years that this sort of played out, review, and ultimately led to the black box warning. And ironically, when the black box warning hit, there was a decrease in the prescriptions written. Everybody was pretty cautious, and the suicide rate went up. So if I remove something that's causing suicide, the rate should not go up. So again, it was other evidence that suggested that really our treatments are not the problem. It's getting people the right treatment at the right time that we need to focus on. This is just a slide that sort of hit home. The most common form of completed suicide is by firearms, male or female.
Oh, is it?
It is. Hanging is had a little bit of a return.
It would be attempted. It would be A for attempted
Yeah, so
suicide in females.
Completed
But completed changes the whole thing.
changes adult. And the reason I say that is when people talk about gun regulation and limiting gun, this is one of the reasons. If I have a firearm available to me,
Amen.
my risk is much higher. Right? So when we talk about regulations and those kind of things, this is one of the reasons it's such an important topic to talk about. All right, so this is my fancy slides here. I'm going to move into this one. So this is a TADS, the Treatment of Adolescent Depression study, sort of the hallmark study in teenagers for depression. It was not drug company sponsored, right? So it's not a biased study. It was by the NIMH, National Institute of Mental Health. It was a large study, so 430 patients who met criteria for depression. That is a large study, particularly in child and adolescent. And usually studies are 15, 40, 100. This was, well done. Severe depression, and they would either put you on medicine, therapy alone, combination, or placebo. So you had sort of 4 possibilities you could get in, and you didn't know, and the person giving it to you didn't know. Everybody was blind. So they were just recording how you were doing. You were just reporting how you were doing. Nobody knew what you were taking. And you knew the therapy piece. All right. But otherwise you were blind. All right. So what do you think the outcome was?
Is therapy the control?
So placebo was kind of the main control, and then you had your therapy only. But you had placebo, so all they got was some support, was kind of your baseline, and everything was related to that. So I had to show improvement over placebo to be counted as effective. Does that make sense?
Mm-hmm.
So all the treatment groups improved. Right? This outcome was measured at 12 weeks. So 3 months out, all people receiving treatment, regardless of treatment, had improved over placebo. The further out you go, the better therapy did. So it kind of caught up over time. It just takes longer. So if I have somebody severe on the front end, my approach would be medicine and therapy because it gets you quicker, and then therapy can sustain over time. And that's the thing that helps you then hopefully come off medicine, but you've acquired skill to hopefully maintain without medicine. So combination is referred to. Now if it's mild to moderate depression, there's not a safety issue, then you're going to start with therapy and not introduce medication if you can. And these were the costs of the treatments. Obviously, combination's the more expensive, right? But it may be more lasting as well. All right, so that's just a good old question that says combination is the most effective treatment. And then you had the Lexapro study. It was sort of the second. So the first one was the Prozac. That's the TAD study. Then Lexapro was able to show similar findings in their study as well. So that's how we have 2 kind of medicines. Now Lexapro is a spin-off of a medicine called Celexa. So we can use Celexa in a similar fashion. So you may see kids on Celexa as a result because it's cheaper and generic as opposed to Lexapro. The Tordia study is treatment of resistant depression in adolescents. So they took folks who didn't respond to their first antidepressant intervention, still depressed, and then put them in this study. Okay, so these were folks who were a little harder to treat. They didn't respond like we'd hoped. And they either got put on another serotonin drug, one of those 3, a serotonin drug plus CBT plus the therapy, or the SNRI, the serotonin and norepinephrine drugs. We're adding a little wrinkle to the intervention, or the SNRI plus CBT. So they kind of had 4 options. And they'd follow them out for a couple of months, I think, maybe 12 weeks ago. Basically, you had some then people respond, which was good. So you took people who weren't responders and about half responded. So that I don't call you a non-responder unless you've had 2 trials. It's basically because you're going to pick up some more people with a second trial. It didn't matter what you chose, interestingly enough. There was no like one medicine that stood out over the others. Just a change seemed to be enough. And the combination was better than just relying on medicine. So again, that importance of the therapy piece, right? Exactly right. If you have a young person you're dealing with who's depressed, you got to ask that. Just they may be thinking it, and then sometimes it's shameful to even admit it. You know, there's stigma, or I can't believe I'm having this thought, or people think I'm crazy if I say this. You know, so you ask, you have a discussion, you see if we can get you help or keep you safe. Not sure what that's about. So we're kind of in there, and certainly we have, a couple minutes for questions. So, thank you for your attention.
Thanks
Any
for
questions?
having
Yeah, absolutely.
How did you advertise this?
It goes through the Depression website, the Depression Center website, and then they'll send stuff to university-wide clinics, the Jefferson County Public Schools. It doesn't get advertised a whole lot.
I know, but
obviously.
I'm surprised you didn't get a better turnout.
It's funny. I've done, it's probably 5 or 6 years. I've done different things, and probably my biggest group was 30 to 40. Evenings, things like that, and that was over parenting. And I did one on video games that I swear I thought was going to be huge. It was like 4 people. So you just never know.
I think that the biggest problem is people don't know.
Yeah, it may be.
I would have been to that one.
Yeah, right. I thought it was a good one.
And I'll be honest with you, like I said, I'm representing NAMI,
Yeah.
which is the National Alliance.
And I would think they would send it.
Well, they brought me with brochures for you guys for our programs, but I hadn't heard about this unless somebody had sent me here.
Oh, okay.
Do you see what I mean? And they sent me here to let people know, because the nice thing about NAMI is, like you said, the whole family, it's a whole family thing.
Yes, ma'am.
And most of our programs are geared towards family members and
Yes.
not towards the consumers. We have programs for consumers, but not children consumers, just adult consumers.
Right.
Consumers are people with mental illness
Yeah.
in our NAMI world.
Yes.
So we actually find that when we teach people more about mental illness in their children or their family member, that they get more success for that person's treatment.
Absolutely.
I mean, it's proven. It's, what's the word they use? It's actually proven. We've been able to prove it, that our results matter.
Efficacious, or I don't know.
Yeah, there's some word they use.
Evidence-based.
Evidence-based, so, yes.
Yeah.
Because, how to get the word out. But
Yeah.
we have the same problem on how to get the word out about our classes. But that's why we come to things like
See,
this.
the dilemma is advertising
Costs
costs.
money.
Yeah. Well, I
Nobody
picked
has
it
the
up
money.
at Bingham. I picked up your.
Yeah, I threw some out.
Yeah, and that's how I found it.
Yeah, supplementing.
Well, but that was, but
That's
That's
why
why we're
it's
here.
true.
Yeah.
Yeah.
And maybe, and I know, if you'd have posted, not saying you yourself or anybody else, like at the libraries
Mhm.
or some Kroger,
Yeah.
on their bulletin boards.
Well, a lot of times Kroger will limit what you can put up. Sometimes
Well,
libraries
I'm not
will limit
necess-
what
I
you can
just
put up.
picked
Just
Kroger,
getting
but
it
I'm
out there a little bit
getting
more.
it out because
Right.
this was so important, and we all know that this affects so many more people.
Yeah, certainly.
In the
Yeah.
pediatrician's offices,
Oh, yeah.
there were a poster. in the
Pediatric
waiting room.
psychiatrist, Dr. Sullivan,
Mhm.
Places like that, 7 counties, the Child and
Yeah,
Adolescent
and
Centers.
I'm probably not, I can't speak fully to who they send them to. I know they do as best, they know if the more they get out there that, so I'm not privy to the list because
Yeah, I'm not going to go to the list either. We're having the
I
same.
volunteered to do the
We're having the
talk,
same
so-
problem you are.
Yes.
So,
Anybody interested?
besides the suicidal thought thing,
Yes.
which is the risk of taking medication, like the SSRIs,
Yes.
is there any other risk?
Right, so getting worse, right, would be more negative thinking. If you're bipolar, You might have a manic switch or hypomanic switch. And then you have like side effect concerns. For the serotonin drugs, you're talking about GI distress, sometimes nausea, loose stools. It tends to get better over time if it's not too bad. It will go away over a few weeks. I can be more irritable, no question about it. Headaches. Right? So you're looking at toleration, probably 10-15% of someone may complain, I'm getting headaches now, or it makes me tired, or I can't sleep now. So you're kind of adjusting to what they're experiencing. But for the most part, they're pretty safe medications. If you look at older antidepressants prior to the introduction of this group of meds, they were much more dangerous in terms of overdose and all these other receptors they hit, things like that. So these, in terms of safer medicines in that way. So they're usually pretty well tolerated, but some people don't tolerate them. Yeah.
From a public health standpoint, what are your other aspects on that besides getting out medication or therapy? Do you think like offering screenings also in school can be beneficial rather than just pediatric all vaccines?
Oh, no question. So prevention, I guess primary prevention is trying to identify, right, groups, people who may be more at risk. And your secondary, you're going to pull them out and try to do something at maybe a school level to help them skill development. And then those who aren't improving may get then referred to treatment, right? Are you in public health? Sounds like you might be.
Public health major. And then also,
so the schools, I will say, Jefferson County Public Schools does do kind of a mental health screening every year.
And then 7
The
counties
dilemma
will go in there.
is what do we do when we've identified this large group, and so they refer then, and then the system struggles sometimes to meet the need, but that is a good step, and they have, to their credit, done that each year for the last several years.
and then also culturally, I know like I did a case where about the GlaxoSmithKline case where they did suicidal medications on toddlers, like infants, and they were killed. So I know some cultures won't even consider medication as treatment for.
I'm not sure I know what you're referring to.
I did on GlaxoSmithKline. They did pharmaceutical drugs about depression medication, but they were supposed to be prescribed for adults.
So they were giving it to toddlers or something?
Yes, they gave it to. They were children that didn't have parents. Sorry, I can't think of
Orphans or something?
Yeah, orphans.
Uh-huh.
And one was done in New York, and another was done in South America. And after the one in New York, I think it happened in 2004, and they gave them prescription drugs for depression. And I don't know if it killed those, but I know some in South Africa. They killed some in South Africa.
Well, there's appropriate concern about over-medicating children. It comes from the ADHD interventions, schools say, your kid needs to be on meds, they're struggling. So you get a lot of influences in that way. And there are treatment providers who rely heavily on medicine, and bad outcomes do occur. I think I know what you're referencing now. So it wasn't a sort of drug company sponsored sort of thing. These were providers treating very young kids with multiple medications, and they made the highlight reel because of the bad outcomes. So I think one was, a 4-year-old who's on 5 psychiatric meds or something like that. And it was up in the Northeast. And that's where you got into the, this 4-year-old has bipolar and this sort of not very good mindset about what we were doing. So yes, sometimes we rely way too much on medication. Now, having said that, there are illnesses that are challenging. So someone with severe autism who's nonverbal, who's self-harming, who we're trying to intervene in a way to be helpful, to have them be safer. You end up doing things outside the box with the knowledge you have to try to help. And again, it's a little riskier than what you're doing.
Yeah, I just know based on American Red Cross how stuff happened with that. What people are against them,
When a lot has happened where drug companies cannot talk to me about something that's off-label, right? They can only present their medicine for what it's approved, and there was a lot of trouble they got into when they were saying, well, you could maybe use it for this, or trying to get a wider net, but they can't do that anymore.
So just FDA approved medication?
Yes. And then they get in big trouble if they go beyond it, yeah.
Where is there in town a good place that like an adolescent, almost adult can receive really intensive CBT therapy like on a regular basis to where it would really help them instead of just, once a week, a couple times a month or.
If I had a transitional age youth, right, that's what we're talking about, the sort of young adults, that gray zone, they're still young, still learning, but they're 18 or 19. I think one area is the University of Louisville. I would say, let's get you with a resident. This is what I would do. Get somebody who's in their training, and they're going to dedicate all their time learning their CBT and working with this young person for a period of 2-3 years. And you're going to get a dedicated person who's not going to have very many patients because they're in training.
Where would you go? The University of Louisville, like the Depression Center?
Yes, exactly right.
Mm-hmm.
At the adult clinic. So we're the child arm of that at Bingham, and down the street at the professor's building is the Depression Center and the adult clinic. And so they have attending physicians. So Dr. Wright is sort of the guru of CBT there, and he would be supervising a group of residents who then have their training clinic, outpatient clinic, and so they're treating adult patients separately. So one officer says, hey, we want to hook up with a good resident. I need CBT. I heard this was a good place
The
to
one
do
that's
that.
just starting now.
Yeah, I want a second year
Yeah.
general psychiatry resident that's going to be here in 3 years.
Not one that's leaving in 3 months.
Say, I'll wait 3 months to get in, but then I got
So
dedication.
Dr. Wright is over.
Right, so I mentioned his name. He's our director of the Depression Center, right? And his area of expertise is cognitive behavioral therapy. And so, he does a lot of the supervising. He has even a weekly group where he supervises clinicians providing CBT to the patients.
Are there any
But I will say, psychologists in town, it's a very common intervention, so you can find people that your question was competent and good at CBT. And everybody, his training's different. And sometimes you got to try a few to make sure you have somebody that connects with your young person and they're clicking and engagement and those kind of things.
And then also a psychiatrist that would be able to do the medications along with the CBT.
Right, so these residents would have that capability because they're general psychiatry residents, so they would have the option to use medicine if indicated or not. So again, it kind of is a combination treatment.
So they would see their patients at the Louisville Depression Center clinic?
Correct.
Okay. And in your opinion, like when they're getting started, how often should they?
Typically, if you're starting CBT, it's usually weekly to start.
Once a week, twice a week?
Usually once a week.
Once a week.
And then you can go for a period of 8-12 weeks. And
I
then
almost think she's thinking more of something like an outpatient program. You're talking about
Yeah.
something 5 days a week.
Not necessarily, anything to where they're sure that he's got it and.
Yeah, day
he's
programs
using those
are
things.
more group driven. You're going to get more group experience. So if you were at a level where you needed daily support, but you didn't need to stay overnight in the hospital, but you went every day to like a partial day program, most of your experience will be group based. You may get an individual experience some of that time, but probably not every day.
Any particular psychiatrist at the Depression Center that you feel might be really good? I know there's a number of psychiatrists there.
Yeah, so they all have their niches a little bit. I think, CBT is kind of you're interested in, you can't do better than Dr. Wright. If it's somebody who, you need somebody older, Dr. Casey, who's geriatric depression, female issues, Kathy Vincent. So everybody kind of has their niches a little bit.
What about DBT? Have you heard anything about?
Right, so DBT stands for Dialectical Behavioral Therapy. Yeah, if you need to go, please do. Thank you for coming.
Thank you. Oh, well, actually,
And is there any benefit to one over the other?
So DBT is a great intervention for people who have trouble self-regulating their emotional world. And so it arose out of treatment for a personality disorder called borderline personality. And these folks tend to have a lot of erratic experiences in managing their emotions. They're very impulsive, very reactive, very angry at times. They can get suicidal quickly and recover quickly. It's very unstable. It tends to impact their interpersonal world. So DBT was sort of created as an evidence-based approach to help teach skill sets, including meditation, mindfulness, self-soothing, life skill, to help somebody with that need. The thing is, it works well for somebody who's developing those anyway, so there's some adolescent spin-offs of DBT, but there's not a whole lot of people in our community that would do that, have that skill set. We do some DBT on our inpatient unit as part of a group teaching kind of model. We're teaching certain skills, mindfulness, things like that.
Is there anywhere where there would be teaching, like you mentioned something about something?
Yeah, let me, before you leave, I do want to mention, we have an adolescent study going on at U of L. So if you have a teenager or know of a teen that might be struggling with depression, and I can give you at least the brochure. They're looking at a different medication.
And you're looking at Unidepression, not bipolar 5 depression.
Right, so part of the criteria they would go over with you to see if you met the study criteria, and that would be one of the questions. So I can give you the contact if that's something.
What age are you talking?
It is,
Do you
let's see
have
that, I
contact
think it's 7 to 17. I think ours is 12 to 17, honestly.
Do you have a card or contact
I do
information?
not, oh yeah, I might actually.
Good, they can be cut out.
I'm so sorry.
Yeah, mine's 14.
On my hand, on the handout is my name on the front there,
Okay.
and yeah, I don't see any cards. So Bingham Clinic is where.
Okay,
Okay,
great.
do
Thank
that.
you very much.
Yeah, I want to make sure I gave those out.
You said your name's on the handout?
On the first slide, I think it is.
It's, yeah. Oh, there we go. I see you.
Print you can't read.
There you go. That's it.
Very tiny. Any other questions for me to finish up?
Yeah, you mentioned something about if an individual is secluding themselves, and it's important that they get out more,
Right.
start an exercise program. Is there any place in town that kind of does something like that, like a group? Or
Specifically for like someone who's
Adolescents.
suffering depression, things like that.
well, yes. Mm-hmm. It has a lot of social anxieties and things
Mhm.
like that.
I don't know specifically of an exercise intervention. There's a guy named Tony Shepard who has a practice called Group Works and offers different types of groups for a variety of ages, youth,
Might
teens.
write that down.
Yeah, Group Works. But I don't think any of them are exercise related. But you have social skills, you have coping, kind of adolescent.
And they would
young
do this in a
kids.
group setting.
Correct. And he's got a nice website. If you
And
type in Group Works, Tony Shepard,
Tony Shepard.
you'll find his website. It's very nice. He's
Now,
got
what
a
is
nice-
he? Is he a,
He's a PsyD, I think, doctor of psychology. Either that or PhD of psychology, one of the two. He's a psychologist.
I have a question.
Yeah.
At what point do you say, this doctor's not working for me,
Mm-hmm.
to go to a different doctor? I mean,
That's a great question.
it's subjective, but and I feel like we try all this different stuff, nothing helps.
Right.
At what point do I say, okay, maybe I need to get a different perspective and go to a different doctor?
Yeah, it's always okay to get a different, even if you're not switching or you just get a different, what we call sort of a second opinion.
Mm-hmm.
Here's everything we've done. Do you have any other ideas? Do you think we're on, it's just the way it is and I
Right.
need to stick with somebody who's just kind of been with it? Or do you have a new idea that maybe she hadn't thought of or something like that?
Yeah.
Very good.
And I've
But
been going
sometimes
for years.
I have patients who are adults I see and we kind of look at each other and like, okay, we need new blood, we need new ideas. You know.
Yeah.
Do you know, Dr. Stephen O'Connor?
Right, so he's a psychologist over in the adult division. He does a lot of really good research with suicidality and safety prevention kinds of things. Yeah, he would be good too.
I was
But
glad-
he's kind of a research guy too. He does clinical work, but he a lot of his work is around his research
His
interests.
research.
Yeah.
I was glad that you mentioned how teens believe things that aren't true.
I'm sorry, I don't mean to laugh. But I'm sitting here thinking of the things my daughter believes right now that are absolutely not true.
Like,
It's so common in children with mental illness, I think, that when I think it with,
Now remember, teens in general know everything.
and at the same time, everybody's out to get them,
You can't.
Yeah.
You
No matter
can't
what.
tell them something they don't already know.
you know?
well, I mean,
And that's just a regular teenager.
Right.
this is a brother that made a comment to him when he was angry. He was going to put him 6 feet under. So my son is now in terrible fear that his brother's going to come in one day
Yeah,
and
yeah.
kill him.
Yeah.
And I mean, how? I just don't understand how they can really believe that.
Yeah. So that's an anxious cognition, right?
Yeah.
And I'm not going to make it, or something bad's going to happen. So when we distort things in an anxious way, it's usually catastrophic, worst case scenario. I'm not going to live.
Yeah, and he just can't seem to get over it.
Very distressing. And the thought drives everything else. So if you can't get that sort
Thought
of
out of your
loosened up,
head, and you're fixated
everything
on it.
downstream is going to be
Yeah.
impacted. And I talk like it's easy to do. It's not. And the younger you are, it's much more challenging because they may not see it or appreciate it as a problem. I'm just having, my brother said this. Of course, I'm worried about it. They may not see it as their role, that we shouldn't believe that, or that's ridiculous, or he loves you, he just was mad at you. He's not putting rationality with it and examining all the pieces of it.
And he won't even see his brother. I mean, it's like,
Right. So, well, of course, for him, that's smart.
Yeah.
I'm saving my own life.
oh, yeah.
And then if you say anything, he's gonna feel like you discount his
Yeah.
feelings.
Very challenging.
That you don't believe him. Or,
Yeah.
I frequently with Haley use a reflective technique back when she starts saying things that make no sense. That would be scary. I can understand why you're scared and just go on,
Mhm.
And I don't agree with them. I never agree with them.
Yeah.
Yeah.
Mm-hmm.
But yeah, it's,
So the thought is a developing brain is probably more harmed by it than one that's more fully developed. And that's where
I
that comes from.
understand that.
And a lot of our systems, in terms of our frontal lobe, judgment, things like that, don't fully kind of finish developing to a certain degree until our mid-20s. And the thing with adolescent brain is our impulsivity and things develops before our ability to sort of hold it in check. So we used to call it, you get your gas pedal before your brakes. So you're a lot riskier when you're younger, and then eventually your cortex says, wait, you got to calm down and quit taking these risks. That you are mortal. There are risks here. And so that part of your brain development, we think, can have a negative influence. There was some literature coming out of, I think, I don't know if it was Norway or Sweden, but they had some really strong data because they have a one health system, public health system, and so they have a lot of information. And they could go back and look at heavy marijuana users who they knew were heavy through adolescence. And they could show a drop in IQ of about 10 points. So if you're using heavily, then it can really have an impact on it. So you're just trying to minimize risk. I mean, unfortunately, it's a different bear, so it seems much more availability. And it seems to be part of the current adolescence. It used to be have a beer, and
it's more
marijuana is kind
socially
of
acceptable now.
right there with it as part of your
Quote.
what's the word, rites of passage in a sense. And it's not the same marijuana that was around in like the 70s and 80s. it's about 10 to 20 times more potent at the receptor. I think it's going to have a much more of an impact. And we even, in some of the synthetic stuff, we see a lot more kids being admitted who are psychotic
Right.
from this synthetic stuff. So this stuff is a chemical that they've created that works on the receptor, and they spray it on dried plant, and then they serve it as an herb. You can buy it. You know, they used to be able to buy it in like an incense, kind of deal,
That's-
at a smoke shop. And they finally caught on to all that stuff. But you can still, get the synthetic spice is sort of the name that you hear. But that's bad news. It really can hurt people's brains.
Well, and I think it also adds to the paranoia.
Yeah.
So if you have somebody that's already
Very
paranoid,
nice,
you're
yeah.
increasing the paranoia.
Yeah, certainly can, for sure.
Just
So it's a
back-
challenge. It
Sorry.
is a challenge. And then, part of adolescence is experimentation and who am I, and figuring out who you are. So you're more kids, probably half, are going to try things like that. And just cross your fingers sometimes.
Yeah, I hope they survive.
Right?
Go on to adulthood.
Well, thank you all very much.
Oh, thank you.
Oh,